All right. So we're just going to hit the ground running?
Yes.
Okay. All right. Well, thank you guys for joining us. This was supposed to be a workshop really focused on teaching the art of motivational interviewing. So the overall plan for the day was, some slides. We are going to have a patient and physician demonstrated BNI from some of our experts, and then we're going to break into small groups to practice ourselves. So these are presenters and facilitators today, Dr. D'Onofrio, McCormack, Coupet, Samuels, and myself. And we do not have any conflicts of interest, but do have some research funding is our disclosures. So our learning objectives are, upon completion, participants will be able to describe the principles of motivational interviewing and familiar with the literature supporting brief intervention and the brief negotiation interview. So just a little bit, because I wasn't sure how many students we would have here, or just a little bit of background on substance use disorders, treatment. The idea was to provide some facts so that you could sort of weave into your BNIs later on this, as you practice them later on today. So we know that overall, only about 1 in 10 with a substance use disorder get treatment. We know that people seen in the ED after an opioid overdose have a very high 1 year and 30-day mortality. So it's critically important that we identify people who need interventions and use our skills to help really connect them with treatment and help them focus on their particular reasons for accessing treatment or for initiating treatment. We know that rates of treatment with MOUD greatly increase the likelihood that you will have a lower death rate if you are engaged in treatment. So this is standardized mortality ratio. General population is 1. Folks with untreated opioid use disorder have an SMR of 6. And if you're able to get somebody onto treatment with either methadone or buprenorphine, you're actually able to get that number down to less than 2. So short story is if you have somebody with untreated opioid use disorder, the best thing that you can do for them outcome-wise is get them engaged in treatment. Lots and lots of benefits, increased survival, treatment retention, ability to gain and maintain employment, better birth outcomes and quality of life, and they have decreased overdose mortality, HIV and hepatitis C infections, and crime. So this is something we're going to talk a little bit about, but the goal around treatment, so it's a spectrum. And particularly when you're meeting people in the emergency department, it is a spectrum of getting people to engage in treatment. So it can either be, and we want to offer the full spectrum of treatment to our patients that we see. So it can either be sort of sustained recovery, complete abstinence from all substances, or it can be really focused on, how you mitigate harms from ongoing substance use. So when people think about motivational interviewing, this is initially a technique that was developed by Miller and Rolnick decades ago, and this is a sort of a quote from their initial paper. It says, motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. And that's actually really the core take-home about motivational interviewing is it's not what you as a physician think someone needs to do or your reasons for them stopping their opioid use or making that other behavioral change. It's really helping someone identify what it is that motivates them. So from a bird's eye view, anyone can do motivational interviewing. This can certainly be done by, physicians are certainly well positioned to do it, but it can also be done by APPs, by nurses, social workers, peer navigators, health promotion advocates. And this is, a technique that we know is very, very effective to enhance motivation, can be done in the emergency department very briefly, and can actually help promote people's willingness to engage in behavior change. So I already talked about it being developed in the 80s. There are more than 25,000 articles sort of citing MI. There's a huge sort of literature basis for us. There are a lot of clinical trials. Obviously, like all interventions, it is, it varies across the training, what you're doing within studies, fidelity, but it can definitely be done in the emergency department. So MI is sort of the basis for a lot of what we're going to talk about. What we're actually going to mostly talk about is, we'll get into the brief negotiated interview, which is a little bit different, but that's where a lot of the ED literature is. So the brief definition is a collaborative conversation style. It's very person-centered counseling or person-centered discussion for addressing common problems around ambivalence for change. And these are sort of the core interview skills that you guys will be practicing today. Practical aspects of MI, you really want to be open-minded. It's really around sort of listening more than asking, more than giving advice. So there's certainly a role for each of those things, but really the goal is for you to be a listener and reflect back to your patient or whoever you're working with, the things that you hear from them, because those are the things that clearly they're thinking about and they're talking about. So it's, these are some other practical techniques: not asking more than 3 consecutive questions, not interrupting, really being cooperative. And, if someone, you don't force knowledge. If someone is not interested in treatment, that's not the time to provide them all of the great data about how treatment is helpful. It's really sort of listen to their concerns and sort of work your way back around if there are things that you feel like are really important to share, but it should really be guided and directed by the patient. So this is the brief negotiation interview. This was is something that is what all of our ED work has done. It was developed by Dr. D'Onofrio and is quick. And this is a slide that was put together by Mike Pantalone, who is a clinical psychologist who's done a lot of work with the BNI in our space in our emergency department. So the BNI has 4 steps. It takes around 5 minutes, and it's evidence-based. So there are sort of 4 key steps. So one is enhancing motivation. So one is, you want to raise a subject, establish rapport. And so I know you guys are all clinicians. You certainly know how to talk to patients, but there's something that's actually very important around around asking someone's permission to discuss their substance use. It gives them an individual a sense of sort of power and control, that you're not talking at them. And so, really you want to raise a subject and establish rapport. Obviously, introduce yourself, but, ask permission. Is it okay if we talk about, your alcohol use, or what brought you to, what brought you to the ED today, or your opioid use? And then sort of think about their physical level of discomfort. Maybe they're on withdrawal. Maybe they're cold. I know we talked earlier today about the importance of blankets and sandwiches and all those things. But this is all sort of part of the first step, which is really establishing rapport. Then you want to provide feedback. So you can review the individual's sort of drug use and patterns. You can ask them about, ask about and discuss drug use and its negative consequences, make a connection if possible between their drug use and medical issues. So if they're in the ED for trauma, for example, do you think the fact that you were out drinking earlier tonight is related to why you have an injury right now? Sometimes people don't see it, and sometimes people do, but helping them make that connection between, particularly the emergency department, where no one was planning to be in the ED that day. So there is clearly something that has affected the course of their day to bring them to the ED to you. And then you can provide feedback on, OUD, if it's OUD, on alcohol, if that's what you're talking about. And then, if based on what they tell you they are interested in, that's sort of where you get to provide a little feedback for them to sort of think about, what the next steps might be for them. Step 3 is enhancing motivation. So you want to assess readiness to change with regard to, with regard to starting preferred change. So the big question is, so on a scale of 1 to 10, how ready are you to make a behavior change right now? To either reduce your alcohol, to stop using opioids, could be to start treatment, can also be very, very harm reduction focused. It can be, how ready are you to keep naloxone with you when you're around people who are using opioids, or use syringes, clean syringes, whatever the thing is. It can be, how ready are you to engage in this behavior change? And then you want to enhance motivation. You can ask a series of open-ended questions designed to sort of evoke change talk, or really figure out sort of what it is, how they are going to make that change, what it is that they are interested in. You want to reflect or reiterate patients' motivational statements regarding treatment. So, and then step 4 is sort of negotiate and advise. So, negotiate goals regarding their target behavior, whether it's, again, starting whatever it is that you guys have discussed is a targeted behavior change. You want to sort of think about, what the next step is. And so that's also another place for you to sort of give advice. Again, this should be very, very reflective of, what the individual has told you their goals are and what their motivations are. And then you give them a referral or sort of whatever the next step is. So this is sort of the BNI cheat sheet. This is from Mike Pantalone in 2018, but it's a little sort of one pager. I'm going to leave this up here sort of as we go through our cases. But I was actually going to see if Dr. D'Onofrio and Dr. McCormack would come and sort of work through an example for us. All right. And should we put
Okay, why don't we
chairs here?
Oh.
Here.
Okay, Mr. McCormack. I'm happy to say I've reviewed all of your X-rays after your motor vehicle crash. Everything looks good. We've already. Can you hear me?
Yeah, sorry.
We've already. I see that the nurse washed your wounds and everything, so I think we're great. We'll give you some discharge instructions about kind of keeping your face clean for the next few days and what things to look at. But I was wondering, now that we've finished with all that, if you would mind if we talked a little bit about your alcohol use.
My drinking?
Yes.
I guess so.
Okay, good. All right. So just tell me about it. On a typical day, how much do you generally drink?
Well, I mean, I know I was drinking last night and I got in a car crash, but like, I've been going through a lot lately. We just, like, last night we were just out, celebrating might not be the right word, but I got divorced. Yes, my divorce was finalized yesterday, and we just went out and I drank more than usual, so it's not like a big deal. I mean, most nights, I've been going through a lot, and, so lately I've been drinking a little bit more.
Okay, I'm sorry to hear about that. So really we're just trying to, we know that certain limits of drinking are less likely to have complications, such as your car crash last night. So what I've just wanted, so in a typical week, what are in the last few weeks, what have you been drinking, would you say? How many drinks? And we talk about a drink as being like one beer, one 12-ounce beer, or one hard drink, which is 1.5 ounces, or
So
maybe one wine, 5 ounces of wine.
Yeah, so like I said, lately I've been drinking more with all the stress that's been going on, and so I come home from work and I have like 2 or 3 drinks. That's like pretty much what I do every night now. I didn't do that before. It's just like, things are going on, and of course, like on the weekends when I go out, like last night was a special thing, and then on the weekends, I'll drink more. Maybe, I don't know, like just like normal, like like other people do, like 6, maybe 8 drinks.
Wow. So we know that if you drink over, for you, and you meaning men, we say that if you drink more than 4 drinks at a time, you're more likely to have some kind of injury or illness. So we kind of like to keep it in that respect. It doesn't mean that even some people can't even drink 1 drink or 2 drinks and maybe cannot drive. But in general, we think that if you can keep it below that amount, that you're less likely to run into some trouble. Do you see a connection between your crash last night and your drinking?
Well, no, I didn't feel like drunk. The road was slippery, and I'm not sure how much I drank, but I felt fine, like I could walk, and I felt like I could drive last night. So I'm not sure I really buy that. I'm getting, I don't know, maybe you're blowing it out of proportion.
Well, I could see how you may think that, but in fact, we almost avoid crashes all the time, right? Like, so the weather is bad, someone in front of us stops, whatever. And we know that last night when you were drinking maybe 8, 10 drinks, as we talked earlier, that will impair your judgment and your ability to react. And sometimes you might not know that yourself, but I can assure you that we know that with that amount of drinking that you wouldn't have been able to stop. And then what happened, that you didn't see that car and you ran into the car. Does
Yeah,
that
I mean, I
sort
guess,
of make sense?
Yeah, I mean, yeah. I mean, I think that, yeah, I don't know that it's like 100% because of the drinking, but I could see that like drinking could maybe have something to do with how it happened. Yeah.
Right. So on a scale of like 1 to 10, and you're maybe thinking that where do you fit along that and wanting to make some kind of change in how much you drink, like 1 being no change at all and 10 being ready to change?
I think a 3. I think 3 is about right. Yeah.
Okay. A 3 is good. That means you're like 30% there. That's great. Like, why didn't you pick a 1 or a 2? There must be some reasons why you wanted to change.
Yeah. Well, I mean, I just feel like I'm in a little bit of a rut where I'm coming home, I'm sitting on the couch and I'm drinking, I'm not getting off the couch. And, that was one of the things that that Sarah used to kind of complain about. And I've been having like some anxiety. Like sometimes I do things when I go out that I'm just not like, I make an ass of myself sometimes, and I lost my car once and didn't know where I parked it, and so there's been a couple of things, but like, so there's a couple. That's why I wouldn't do a 1 or 2. Yeah. So there's been a couple things.
All right. Well, that's great that you've brought up those times, because that sounds pretty frightening, and that you might do some things that you wish you didn't, or you lost your car, or sounds like this might have been some contribution into your problems with your relationship. So sounds like you have some really good reasons to want to change.
Yeah, I mean, it's kind of weird to like, with everything going on, to talk about it right now, or like to think about it, where it's all kind of coming to the surface. So I might be making a bigger deal out of it right now, just thinking about it. But yeah, can see that there's some things that, yeah, I think that the more I think about it, there are some things that would be good to change.
And it seems like at this point, maybe you need more of your wits around you to try, because you have things you need to work on and things that are happening in your life that maybe you would be more likely to think of a clearer path. Does that seem possible?
Yeah, I mean, I don't want to stop drinking. I mean, there's things I like,
Okay.
But
so
yes.
what do you think those next steps are? We talked about what I said was low risk drinking. It's not no risk drinking, but it would be lower.
So what did you say it was again?
I
It was
said no more than 4 on the occasion. 4 standard drinks. So what kinds of things do you like to drink? Beer or
Well,
wine?
it depends. Like, well, I usually when I go out, I'll start with like a Jack and Coke, and then we go to beer. And at home, it depends on the day. But yeah, I drink usually like a Jack and Coke.
Okay,
Coke,
so
Jack
like
and Cokes.
one real 1.5 ounces is the standard drink. So sometimes when you go out to a bar, that's probably what you get. If you made it at home, it might be 5, right?
Yeah.
So if you could stick to no more than 4, it might even be better to stick to 2 or 3 for right now. But do you think you could do that?
I mean, I can definitely do that during the week. I think it will be hard when I go out with my friends, but like, I mean, it will be hard. I don't know if I can do it. I think, but yeah, I mean, yeah.
And do you think that maybe you could do that just a couple of days a week?
I would, yeah. I think that, in talking with you, I think that like me drinking that every night, and somehow I'm like not doing the things I used to do at night, and I think that I could see, yeah, I'd like to try to do that.
Yeah, sometimes we get more disorganized when we drink. We think we're doing it to relax, and then we don't get our work done, and we get disorganized, and then we go, oh my God, now it's the worst thing. I got to start over again tomorrow, and I didn't do anything I did last night, or I don't sleep as well.
Yeah.
So
you get it. You know what I'm talking about. Like I have
yeah.
so much trouble sleeping, and it's like that's one of the things. Like drinking helps me sleep sometimes.
Yeah.
But, like,
Well, it helps you go to sleep, but then you wake up, right?
Yeah.
Yeah, because we know that it interferes with our levels of sleep. So often we fall asleep right away, but then we're up 2-3 times and then we wake up tired. So it sounds like for all those reasons that we talked about, you have a good handle on wanting to drink less. And so we're talking really about, and I want to write this down so that we remember it when I send you out. So you're going to
That's
drink.
probably smart with me.
So you're going to drink maybe 3, at the very most 4 drinks at the very most at each occasion that you go out, like each evening. And you're going to limit that to 2 or 3 times during the week.
Okay. I
Right?
think,
Now,
yeah.
you might be able to then make it even less, but we could start there.
I think I'd be willing to make that a goal.
Okay, good. All right, so we'll write that down, and I want you to, we'll talk about your follow-up from here, and then maybe you can have more discussions with this later with your primary care doctor.
Yeah, that other doctor that came by said that they're going to set me up with one, so.
Okay, cool.
Yeah.
All right. All right, thank you.
All right, thank you.
Yeah, so it's fine, right? Yeah, we're on that. So you don't often have all that time. I think that's what we could say. You don't have all that time. And if you just went over the feedback, I'm concerned about you, because you had the car crash and this, and let's talk about how we might lessen your drinking patterns, and then you just talk about that. You can do that. It may not be as good, but it works. So people don't have to think you have to do every single thing every single time.
Yeah, and I intentionally, because you're an expert and we're showing this to other people, put some things that made it a little harder, and so that's longer than I think a lot of times it would typically be, but like, just, there's some nice nuanced conversations that you can show people how to do, so glad I got to demonstrate that.
We can talk that if someone picks a 0, right? If someone says, I'm not going to, I have nothing, a 1, whatever you want to call it, 0, I'm not changing, then you can say something like, okay, well, what would have to make you want to make a change, right? And you can imagine if I said, well, what would have to make you change? You got to die? That's not the way we would do it, but just, well, what would you need to make a change? And if I said that to you, you might say,
I might say, like, if I hurt somebody in like the car crash, that would, I think that would be a change, or something I would feel compelled to do that, or if I got in trouble with the law.
yeah, well, that almost happened today.
Yeah, well.
Okay, that actually did happen, and they brought you in. I think sometimes when the police bring you in, they may not follow up on what happened in terms of your alcohol use, but that really did happen, So
Yeah.
you can just say
Yeah.
something like that, or, well, we're trying not to make that happen, so that's why we're having a discussion. And almost always people will come out with something. Always, always. I think in thousands of patients, I have never heard of someone just sitting there and not saying something.
Wonderful. Do you guys have questions at all? About that, comments, anything?
Sure, I'll throw it out. What do you?
Oh, sorry.
What do you do? And I'm sure you've never had a patient like this who comes in after their overdose reversed with Narcan, and says, "What? I didn't do any opioids. What are you?" How do you nuance that conversation?
Well, it's possible that they didn't, right? It's possible that they were using cocaine. Yeah, it's possible that they were using cocaine. I mean, it is possible that they weren't using. I almost never have seen anyone not say what they're doing. If you go in a non-threatening way, and you say, may I talk to you about something? I have really never, ever in all my life had someone say they wouldn't talk to me. I always say it in a nice way, and they might say, I really don't feel like talking to you, but what? But I have never had anyone, you're not getting them when they're intoxicated, and you're not doing it like just as the reversal happened, you're waiting a minute or two. But I've never had anyone not say, okay. And then if I don't have people really denying use, except in those people who really are really freaked out and they'll be freaked out. They'll go like, I don't know what happened to me. And then we might talk about what do you use, and then go on from there.
One thing I'm at for the person who's maybe reluctant to trust, I tend to start with, you're not in trouble. I'm worried about you. And like, you came in today, you almost died. So I don't want to help you. You don't have to say like the died part necessarily, but I think coming from a place of like, I'm concerned for you, something happened to you, instead of like, well, what did you do today? can make a very big difference, I think. And then just to Gail's point, the drug supply is so, people don't know what they're using. There's so many combinations of different things. Like it gets sold one thing, it's another thing. It is very complex. So I would just keep that in mind. Like a lot of people they really might not have any idea. And they're just as surprised as you are. Yeah.
Well, and so thank you for that question, because I do think there's something a little bit special about the post-overdose patient that is a little bit different than, after trauma or something like that. And so I think, sometimes they do say, I didn't use anything at all. I have definitely heard that. But the thing that I often do, particularly in the post-overdose patient, that is like one of my favorite go-to moves is just to ask about naloxone. If they were somebody who was out and they got naloxone, it's like, oh, so you didn't use anything, that's fine. But then, actually pivot and be like, oh, what do you know about naloxone? Can I give you some naloxone? We think it's a great thing to have out in the community. Like even if you can't, the goal is of course to try to get them to talk about their substance use, but that's been sort of a way around to show that, you are trying to meet their needs, that, you're not just trying to yell at them to not use drugs, and, and you can also put naloxone in their hand. And I've definitely discharged people with naloxone who have come in after an overdose who never acknowledge any drug use at all. And you're like, well, this is a good thing to have out in the community. And, maybe they're just not ready. But I do think your point is true that, like, often if you provide a safe, non-judgmental space, sometimes people are more, it takes, they open up, they get there eventually, even if they don't necessarily start there.
I think this, I've had this happen a number of times, and I think the word that you use, pivot, is really good. And I'm glad that Liz brought up trust. And I think that just pivoting, whether it's your position or coming back or just explaining, trying to figure out what their barrier is. I had somebody say that to me recently that I ended up starting on buprenorphine, and then afterwards she's like, I told you all that stuff because I just didn't feel like dealing with you or anything. And so some of it's not trust, some of it's just the hassle or what they're going through, and just that's where a lot of what I love about the kind of the motivational interviewing concept is, even if you're not in addition to like kind of the formula and everything, it's just like it gives you practice on how to engage somebody. Like patients with substance use can be very difficult to engage and have a lot of reasons to have diminished trust in us and others. And so just figuring out, we don't always know what their reason is, and just trying to be present and figure that out.
Gail, do you want to talk about how you use motivational interviewing outside of?
I just want to add one more thing that I feel like is helpful for our residents, is I think that a lot of times emergency physicians want the like win of like, we started them on treatment today, and like that, there's nothing else is a win. But this framework, I think, allows you, like, our job is to keep the door open. And like, yeah, the goal is to get your treatment. The goal is to help people not die and to like live like self-fulfilling lives. And like, you may not always like see the win with motivational interviewing, but it's kind of inching them along, right? So that he was at a 3, but maybe this conversation later today, he's reflecting on it, and then he's a 5, and then eventually gets, down the line to like a 10. And like those, maybe for us, that's a little bit less salient, which can be challenging, like to the clinician, but if they know they can come back and get care, or the next interaction, you're kind of priming them, kind of. So I think it's what is success and victory in those moments is important to change our framework a little bit. Like ultimately, yeah, it's getting people on treatment, like helping them, not die, but there's like many steps along that way, and we're like trying to nudge them down that path.
Yeah, I think that's a great point. And there's literature in the cocaine literature about having several different sessions that people talk about it, that eventually people will make a change. So it may not happen right there. And if someone's really not wanting to talk, or I'm not making a change, your point isn't to make them make that change, because you're not doing anything. They'll just say whatever to get out. So that's not your point. Your point is just to say, okay, well, let's just agree to disagree over that. And I'm still going to give you what I consider the low risk limits, or I'm still going to tell you I really don't think you should use that heroin or that fentanyl, and I'm going to give you the Narcan, but, let's just agree to disagree. It's not to change their mind. That's why it doesn't go on for hours or length of time. It's a very short interaction. And you're just concerned. Just like you said, I'm just concerned. I like to do whatever I can while you're here, and we're always here if you want us. So the other question is, MI is like a wonderful skill for anything in life. So I had 3 teenagers. I still have done it. I did it with people who I was their supervisor for any reason. And you want to affect some kind of change in somebody, it's the same idea. You might not say to them on a scale of 1 to 10, blah, 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 right? But you're asking them, tell me about what you want. And then they discuss something, and you reiterate the positive things about it, or things really that there could be a change, and then you get them to decide what they'd like to do about it. And you just go with that, right? And then you hold them to it. Right? And then you hold them to it. They made the deal, right? So that's it.
I'm glad you brought that up, because the question I was going to ask, I'm obnoxiously loud without it, it's okay. I'm glad you brought that up, because the question I was going to ask pertains to that. What you're sort of referencing is like the broader self-directive actualization coaching type approach, right? And in its best, most purest form, when someone can identify the own change they want to make and the own outcomes that define that change, that's usually going to be the most successful. But I noticed some of the questions you would ask, and understandably so, were a bit directive of like what a change would be. What are the parameters, right? Because we know what the literature says, how much should or should not be. I guess, how do you draw the line between a little bit of the telling and saying, hey, do you agree with that? Or trying to float it out there to the person to see if they can come up with something that really is from within?
Well, it should be really within.
Totally.
And I think probably it has to do with how much time you have, how good at that you become. But I think that in alcohol, there are clear guidelines. We know it and they're going to change, by the way. They're going to get worse. They're going to get less. But there is some science associated with that. And so as physicians, we're going to tell them, this is the science. This is what we know. We don't know that, and that's what drives me crazy with THC and the marijuana, with cannabis. We really don't know how much is okay to use. We don't know that. And so that becomes a much more complicated discussion. And certainly any other use of white substances can kill people. As we know, like even in cocaine, people are using cocaine and they're dying. So, we have to say that. We just say it, and then
I think the key point, what I would take from that is there are facts about effects and amounts, et cetera, and then what the actual change manifests as is still what comes from within. Yeah.
I do think, though, I think for people, especially who I'm treating opioid withdrawal symptoms for with bupe, and we're like waiting for the med, like there is like this like cycle people go through sometimes where maybe they're a little unsure. You have to remind them of the goal they set for themselves. It's like, remember how you don't want to die, and like remember how you told me you wanted to get. I'm reiterating back to them all the things we talked about in our conversation, while I'm kind of like, are we getting the med, or what is going on? What is going on? It's like, please stay here. Like, stay here. We're going to help you feel better. We're going to like realign with your goals, because those like very easily, even when they can define them, the discomfort of withdrawal can like really start to kind of make that fuzzy and out of focus a little bit. So I do think that it's not, especially those waiting periods are a little bit more, or if you're like,
Yeah, and it's hard because they're going to die. So you kind of, I often will just say, how about we just try it for a week? If you don't like it, I'm much more assertive in opiates than alcohol. Like, most likely people with alcohol use disorder are going to have a long time of in and out and before they're going to die. But in opiates, you feel so horrible that, next week they could be dead. So the conversation is more of, is there some way we could try this for a little bit? And if you don't like it, you don't like it. Let's try it. Because there's so much ambivalence around treatment. That's why I think the 30-day doses people don't like to take in the ED, but hopefully this 7-day dose, they will take it because it's a week. They don't want to make a commitment that I'm not going to use for 30 days. But they might make a commitment for a few days. And we've done that many times, and people have done well and gone on. And there are people who don't do well and cycle back.
I totally agree that the pressure of it seeming like a forever decision, people are really overwhelmed by that. And so even if it's well, why don't we just help you feel better? And then you can make a decision when you're not feeling sick. That can, I think, lower the activation energy a little bit for them.
The only other piece I want to add too, it's just kind of echoing things, is just the idea that you want to kind of elicit that cognitive dissonance in the person and make the reasons they had to change already that may have been buried deep underneath. You want those reasons to come out, and then you hope that their behavior is consistent with those reasons that were kind of buried underneath. And so they might be buried underneath all of these other ideas of hey, I want to celebrate with my friends, or I want to do this and that. But underneath all that could just be that hey, my family cares about me. They're getting frustrated about it, and that's buried underneath. And so the idea is that you want their behavior. Perhaps it's even then just taking naloxone, just bringing it home with them. So you want that behavior of taking home naloxone with them to be consistent with, hey, I actually care about, my family. I care about my life. I care about my health. And so it's really just highlighting that idea.
So we were going to do small groups in cases, which doesn't seem like necessarily a great move for now. But that means that you each get your own, so there's 3 cases, and there's a sheet for the patient, there's a sheet for the clinician, and then there's actually a checklist for an observer. So what you can do is you can take these home and think about maybe doing these with your residents or medical students or other things. And we can certainly talk through some of the cases if that's helpful, but I also know we're in the last session of the conference. And so I don't want to force anybody into small groups or practicing. But I do think practicing is definitely how people get comfortable with this skill and good at it.
That was one of the comments that I wanted to make, and had to go with using this in other realms, is we know from literature on barriers to treatment that clinicians often don't feel comfortable initiating or having these conversations, and so that's a barrier to the whole from screening to treatment. And so I just think that having a simple framework like this makes it a structure is nice, and you can practice this. That you could use this framework when you're talking about adherence to medications for diabetes, and so I think that you can start in those realms. You can start with the easier, the patients that are a little bit easier to deal with, to get practice, and then you can always, and then you don't have to necessarily follow the structure. You can kind of roll with it a little bit, and you'll get comfortable, and it becomes a little bit more enjoyable. But and also just recognizing your own emotional bandwidth, your bandwidth altogether. So there's time, there's resources. You may have a million things going on, people crashing, and so you don't always have time, and you also don't always have the ability to be as empathetic as you can be at other times. And just recognizing that and accepting that you're not going to be perfect all the time. And if this doesn't go well, it doesn't mean, or if somebody says something that doesn't reflect everybody and every experience. And just, it's so helpful, and makes the change in my dynamic and interactions with patients, it feels so much more therapeutic and is rewarding in a way that is the opposite of how I feel when I'm feeling burnt out. It's I'm making a difference, and I'm getting somewhere, and it's the healing part of, it's what I kind of consider what medicine and health and healing should be. And so it brings me back to that.
And I think too, it's just as we previously mentioned, I think it's just a technique you can use in your personal lives on a day-to-day basis. You may not be ready to try it like prime time during a busy shift, but yeah, on your personal lives, I'm sure there's so many opportunities to use these techniques, especially if you have kids. So.
My husband would always say to me, what's going to happen when that doesn't work? Right? I go, well, there's always plan B.
Yeah.
Plan B is I told you so. That's it. But it's much better to do plan A. And a kid would say to me, you're doing that to me, I can tell it. You're doing that thing to me, aren't you, Mom? And I go, well, yeah, but you get to make the choices. You get to decide. We have the end point, you get to decide the choice. And we just hold you to it, right? But it doesn't work, you go on to
Yeah, I think it's a refreshing change from the paternalism that's existed in medicine for so long of being adversarial and confrontational with patients. So, yeah. Does anyone have any more questions?
Thank you, guys.